morning, ladies and gentlemen. Thank you so much for the opportunity to speak with you all today, and Renee for the introduction. So just a brief introduction on stroke. So most of us have heard of strokes before, but many of us might not be aware of how detrimental they are. So strokes affect one individual worldwide every 2 seconds. So this equates to upwards of 15 million people worldwide each year. Of all stroke sufferers, approximately 1/3 die, and a third will be left permanently disabled as a result. Now, despite significant improvements in stroke prevention and management over recent years, the number of strokes is still predicted to rise by the year 2028. Now, as Ryan so eloquently described, as with stroke, we actually have a primary and a secondary injury process. Now, primary injury in stroke arises due to occlusion or rupture of one of the cerebral vessels in the brain that is supplying blood to the tissue downstream. Cells in the brain really rapidly succumb to the reduced oxygen and nutrients that arises as a result of this. Due to this, treatment must be administered in a really timely manner, and this is the hallmark of treatment for stroke. As for every minute that treatment is delayed, approximately 1.9 million brain cells die. Now, due to this, unfortunately, many patients receive treatment in a more delayed fashion. Now, this may be because they don't recognise the signs of stroke early, or they may be located rurally, for example, and unable to reach hospital in a really timely manner. Because of this, many patients go on to develop these secondary complications, so these secondary injury processes. And most devastating of these is the development of what we call cerebral edema and the associated rise in intracranial pressure. And this is actually the leading cause of death in the first week following stroke, associated with a mortality rate of up to 60%. So in this image here, we can see this nice healthy brain with these sulci and gyri, whereas in the other image, on this side, we can see this really kind of evidently swollen brain. We kind of get flattening of the structures in the brain. Now, because of this swelling, obviously the brain is contained within that fixed cavity of the skull. This leads to a subsequent rise in pressure. And it's this elevated pressure that can have really devastating impacts and lead to the high morbidity and mortality that we see. Now, unfortunately, despite the prevalence of cerebral edema and elevated intracranial pressure following stroke, our treatments are mainly symptomatic. So they actually target the symptoms of the stroke rather than targeting the underlying cause. And this has been really the underlying kind of purpose of my PhD to date, is actually looking at how we can develop a treatment that targets the underlying cause of the edema rather than the symptoms, so we can prevent the development of edema and intracranial pressure rather than treating the symptoms. And thereby we can hopefully improve the management and the outcomes for patients affected. And this led us to have a little look at a process in the brain called neurogenic inflammation to see whether this could be a potential target. So this image on the screen here, if we imagine one of the blood vessels in the brain, we cut a cross section through. This is just diagrammatically what it would kind of look like. So we can see it's this complex kind of structure with these different cells that it comprises. And we also have this really high density of what we call C fibers. So these sensory C fibers, these nerve endings that kind of ensheath the vessels. Now, following stroke, these little fibers get activated. And so if we have a little bit of a closer look in at some of these structures, we would see something like the following. So these pink cells represent these little cells called endothelial cells that line the inside of the blood-brain barrier. And what happens following stroke, when the C fibers become activated, they release this neuropeptide called substance P. Substance P then actually binds to its receptor, which is called the NK1 receptor, which is expressed on the endothelial cells. Now, when this happens, we have kind of this internalization of the receptor ligand complex, which then actually draws this orange structure called albumin from the blood into the brain. Now, this kind of creates this kind of change in this concentration, which actually pulls water abnormally from the vessels, so inside from the blood, into the brain tissue. And as we can imagine, if we have this abnormal accumulation of water in the brain tissue, this causes swelling and leads to the rise in pressure. So this has been a hallmark of a lot of Bob's work and Renee's work over recent years, is how we can actually look at how we can actually prevent substance P binding to its receptor through administration of what we call an NK1 receptor antagonist. So preventing that binding thereby preventing the downstream processes, preventing the brain swelling, and therefore improving outcomes for patients. So how do we actually go about evaluating this experimentally? So the first step for us was really to look at when pressure actually rises following stroke in an experimental model. So this is incredibly important so that we're able to really guide administration of a potential therapy in a timely manner, so we can kind of extend that therapeutic window that we know is a huge limitation for stroke patients to ultimately improve the outcomes. And with stroke with reperfusion here, so this is really replicating kind of what we see clinically, where we often patients have an element of reperfusion, so they receive some kind of treatment. What we saw was that intracranial pressure, so ICP, was significantly elevated out to 5 days following stroke and remained elevated out to around 6 days and began to resolve around 7 days. And this increase in pressure that we saw occurred in conjunction with this kind of evolving cerebral edema, as seen here on MRI, and also evolving midline shift. So when we have this really swollen, stroke-affected hemisphere of the brain pushing itself onto the other side of the brain, and causing some displacement, as indicated here in the blue. Furthermore, this development of cerebral edema that we saw was also associated with an increased breakdown of the blood-brain barrier. This can be seen in the MRI image with this kind of leakage of this contrast agent called gadolinium into the brain, and also in these histopathology images here where we can see this brown kind of staining actually represents that albumin, so that large protein that's abnormally going from the blood into the brain. So it's indicating that we have more of this kind of barrier breakdown and more fluid then permitted into the brain tissue, leading to the rising pressure that we saw. So given we knew experimentally when that rising pressure actually occurred, we wanted to look at how we could administer our therapeutic agent in an effective manner, in a timely manner, that we could really, again, extend that therapeutic window. So to look at this experimentally, we chose 2 different treatment regimes. We chose an early treatment regime, so looking at that 1 to 2 days post-stroke, quite immediately, to see if we could prevent a rise in intracranial pressure. And we also chose a delayed treatment regime. So when we gave the treatment actually at that 5-day time point, when we knew that that was when pressure was raised, to see if we could bring the pressure down. And what we saw in our model was following administration of the NK1 receptor antagonist, is that it significantly reduced intracranial pressure when administered both early and in a delayed fashion following stroke when compared to vehicle. So this is stroke with no treatment. The light blue is the early treatment at 1 to 2 days, and the blue is the late treatment at 5 days. Furthermore, both treatment regimes were associated with a decrease in cerebral edema and also a decrease in that midline shift, so where we have pushing of the affected cerebral hemisphere onto the other side of the brain. So a little look into the future directions of this study. So we're now starting to have a little look in the last few months of my PhD, finishing off the analysis, in the effect of this treatment on functional outcomes. Now this is incredibly important because it's really great, obviously, that we can say that this treatment works to bring that pressure down, but we want to ensure that the treatment also leads to favourable outcomes, in the patients that are treated with. So in conclusion, we've shown that the NK1 receptor antagonist, is effective in reducing intracranial pressure when administered both early, following stroke, and in a delayed fashion, following stroke with reperfusion. Now, excitingly, the NK1 receptor antagonist passed phase 1 trials in 2017, and it's now commenced in phase 2 trials in 2018, both in Australia and the UK, with the US start date pending. So a huge thank you to the support of everyone over the last, 5 years now. Especially my supervisors, Professor Renee Turner, Anna Leonard and Claire Jones, and also Bella, who's here, one of the PhD students who helped with a lot of the work, and also my collaborators and mentors, and also to the Neurosurgical Research Foundation for all your support over the years. So thank you very much.